Hi, my name is Sanjay Verma. I'm here in Washington, D.C. at ACC with fellows in training on the go. And with me I have Dr. Ananthasubramaniam, who is the director of the non-invasive lab at Henry Ford. Thank you for joining us.
Thank you, Sanjay. Pleasure.
So we know that you have a lot of active work with non-invasive imaging, and you're also presenting here on multimodality, and we're wondering if you could talk a little bit on that for fellows who maybe didn't get a chance to go to that.
Sure, Sanjay. As you very well know, there's been a lot of controversy on use of imaging, particularly in coronary disease and LV dysfunction. So actually the focus on my talks are to reiterate that advanced imaging is still helpful in challenging cases of severe LV dysfunction. I'm mainly focusing on how to avoid errors in using a single modality for assessing LV function. In this specific case, we are illustrating the role of MRI in a patient with multi-vessel coronary disease who was initially deemed not a good candidate for revascularization, but with additional imaging and recognizing the pitfalls of the imaging, we were able to offer therapy for this patient.
Thank you. Also see coronary CT becoming more involved in assessment of patient care, but also not clear exactly what benefit it might have. Wondering if you could shed some lights on where you see coronary CT going in the near future.
Thanks, Sanjay. Yes, indeed, it is a very hot topic, and coronary CT has made huge strides. And I think with once the trials such as PROMISE trial, etc., which compares coronary CT to stress testing is published, we're really going to know where CT stands. It is my perspective and belief that with such dramatic reductions in radiation strategies, CT is going to become near first line in patients with intermediate risk probability who need assessment for coronary artery disease.
Thank you. I know that you're also very involved with imaging in the context of structural heart disease. Wondering if you could shed some light on its role in both diagnosis and therapeutic interventions.
Thank you again. And this is a fantastic area for echocardiography. Really, echo has broken through many barriers, and the degree of immediate support that echo provides is unparalleled by any technology. So echo is here to stay, and three-dimensional interventional echocardiography is the gold standard in my mind for peri-procedural planning as well as intervention guidance.
Thank you very much. Lastly, in the context of the broader healthcare resource utilization, wondering if you could shed some insights or comments on where non-invasive imaging fits in terms of preventive cardiology as well as appropriate use of resources for the society at large to avoid unnecessary interventions.
I think that's a great question. We talked about all the advanced imaging techniques, but it's very important to understand that in this day and age, the use of imaging really is being policed. So we as physicians really need to take control, make sure that we're not unnecessarily imaging patients, use the appropriate use criteria, and make sound clinical decisions. Towards that effect, I would say that imaging, particularly stress testing, really has no role in asymptomatic patients. I think that's an area where in future calcium scoring is really going to dominate as a great way to pre-screen patients who may or may not need any further testing. Followed by that, in symptomatic patients, CT imaging / stress imaging would be very helpful. Finally, in the prognostication, I think stress testing really should be the first line.
Thank you very much.